I am Dr. Edward Gaber. This video is about diabetes. Diabetes, as everyone knows, is when someone has high blood sugar. 2 out of 5 Americans will eventually get diabetes. And there's a 50% higher chance of diabetes in some ethnic minorities. Diabetics die 6 years earlier than non-diabetics if they're in poor control. The blood sugar rises when the sugar cannot get into the cells, either from defects in insulin secretion or insulin action or both. There can be no symptoms of diabetes, or the blood sugar can cause excessive thirst, excessive hunger, or excessive urination. This is called the 3 polys: polydipsia, polyphagia, and polyuria. Diabetes also can cause visual blurring and fatigue, especially after eating carbohydrates, and recurrent skin infections or abscesses, or recurrent urinary tract infections or yeast vaginitis. Remember that bacteria love sugar, and the increased blood sugar is not just in the blood, but it's in the skin, the sinuses, the lungs, and the urinary tract, predisposing those areas to bacterial and fungal infections. Impaired glucose tolerance, also called prediabetes in the past, begins several years before full-blown diabetes and may be the result of obesity or inactivity. This condition is defined by an A1C between 5.7 and 6.4. A normal A1C is 5.6 or less. Also, if the blood sugar is greater than 110 fasting, but less than 126, there is impaired glucose tolerance. With the glucose tolerance test, if the 2-hour after glucola blood sugar is between 140 and 199, this is also called impaired glucose tolerance. This condition can be reversed with exercise and sometimes even 6 to 8 pounds of weight loss. Even pre-diabetics have a 20% increased risk of stroke and an increased risk of vascular dementia with senility. So it is important to get rid of even pre-diabetes. True diabetes is defined by a fasting blood sugar of 126 or greater, or an A1C of 6.5 or more, or a random blood sugar of greater than 200, or a 2-hour post-glucola blood sugar of 200 or more. The many types of diabetes include gestational diabetes of pregnancy, non-insulin-dependent diabetes, and insulin-dependent diabetes. There is type 1 diabetes, also called juvenile diabetes, which occurs after age 5 but can occur as late as the late 30s. This is an autoimmune disorder where the beta cells of the pancreas are destroyed by the immune system. These patients are usually insulin dependent. Type 2 diabetes usually occurs in adults but can also occur in children. One can tell the difference between type 1 and type 2 diabetes by getting a C-peptide level, glutamic acid decarboxylase, GAD antibodies level, insulin antibodies, or islet cell antibodies. We fear the diabetic complications, which we often see in diabetics who are not well controlled for several years. These patients get diabetic retinopathy, which is a proliferation of tiny blood vessels in the retina, in the back of the eye. These tiny vessels can bleed and lead to sudden or gradual blindness. They can, however, be zapped with a laser, and this procedure can prevent the bleeding and blindness. Considering this, the most important thing I tell my diabetics is to please see their ophthalmologist every year. Uncontrolled diabetes can also cause kidney failure and eventually the necessity for dialysis 3 days a week for life. The first indication of kidney damage is small amounts of protein in the urine. And this indicates that the inner lining of the millions of tiny blood vessels inside the kidney are leaking protein because of the injury from high blood sugar. Because of this, a yearly urine microalbumin is indicated. Uncontrolled diabetes can also do damage to nerve fibers, and the longest nerve fibers are affected first. So the diabetics lose sensation in their feet or get burning sensations in the feet from small fiber neuropathy. Uncontrolled diabetics also get vascular disease of the large blood vessels, which gives them a 2 to 5-fold risk of strokes. There is also a much higher chance of heart attacks, peripheral vascular disease with limb amputation, impotence, and narrowing of the large arteries to the kidneys, which then can cause hypertension. With uncontrolled diabetes, there is damage to the large blood vessels, but also to the very small blood vessels. This one-cell layer lining of all the blood vessels is called the endothelium. It is, in fact, the largest organ in our bodies, as there are thousands of miles of large and small blood vessels. Small blood vessels are inside the kidney, in the retina, in the back of the eye, and supply blood to the nerve fibers and the ligaments and tendons, and can cause great damage in these areas. Diabetics get more sprains and ligament tears because of this, and Dupuytren's contractures are also common. This is thickening of the ligaments of the palms because of the problem with the tiny blood vessels that feed these areas. We can determine if there's good control of diabetes with an A1C. The A1C is a measure of the sugaring of hemoglobin in the red cells in the body. This gives us an accurate blood sugar reading of the average blood sugar over the past 3 months, but especially over the past 5 weeks. This can be influenced, however, by anemia, and the A1C can look falsely better if a patient is anemic. Also, fatty liver can affect the A1C. If a diabetic keeps his A1C less than 7, but ideally less than 6.5, much fewer complications of diabetes occur. In fact, for every 1% lowering of A1C, there is 16% less heart failure, 40% less peripheral vascular disease and amputations, and 13% less strokes and heart attacks. Other studies show good A1C control can decrease the incidence of retinopathy and neuropathy by 70% and proteinuria by 40%. There are other ways to help diabetics. One of them is to get their LDL, bad cholesterol, less than 70. Even better, the LDL particle number less than 700, or the apolipoprotein B very low. My own determination of how low the apolipoprotein B should go is based on measuring the common carotid artery intimal medial thickness in my patients over many years. I believe the apolipoprotein B level should be less than 60, with any significant plaque in the carotid arteries or demonstrated coronary artery disease. Now, diabetics should read labels and count carbs. And with all the many low-carb foods available today, it is quite possible to keep the total daily carbs less than 50 grams per day, not 50 per meal, but 50 grams per day. It is also important to know that sugar substitutes, including sugar alcohol, can stimulate the brain, which then tells the pancreas to secrete insulin, which is lipogenic, fat-producing, fat-creating. So we try to get patients away from Splenda, Sweet and Low, NutraSweet, and even stevia, as they also can affect the bacteria in the gut, the microbiome. Also, sugar alcohols in drinks and energy bars can cause gas and diarrhea. Avoid maltolol, xylitol, erythritol, sorbitol, and also polydextrose in some energy bars can cause diarrhea. One of the real tricks of a diabetic diet or a ketogenic diet is not to eat over 100 grams of protein a day, as the amino acids in the proteins can convert to glycogen in the liver, which then increases the blood sugar. In order then to get enough calories, without going over 50 grams of carb or 100 grams of protein a day, we must eat more fat. The fat should be mostly monosaturated fat or omega-3 fat, extra virgin olive oil, avocado oil, nuts, fatty fish such as salmon or sardines. Olive oil is also high in polyphenols, which are good for us. I believe all nuts are good except for cashews, which are high in carbs. And almonds should be avoided if a patient's had small bowel obstruction. Nuts should be chewed very well to avoid causing diverticulitis. It's fat, not protein or carbs, that turns off the local gastrin hormone in the stomach that causes hunger. Broccoli, cauliflower, green beans, and asparagus, and a big salad with lettuce and tomatoes, avocado, and olive oil should be daily staples in a diabetic diet. Avoid sugar, pastries, candy, ice cream, and sugar-containing soft drinks that, by the way, contain a teaspoon of sugar for every ounce. Fruit juices and fruit can raise your blood sugar. Strawberries have the lowest fructose content and are acceptable, but always buy organic strawberries. Bread and potatoes convert immediately to sugar. There's a bread called Solo bread, S-O-L-O, that has only 4 carbs per slice and is very good. Cereals are basically pure sugar, as the grains convert quickly to sugar. But also, the amount of pure sugar added to most cereals is very high. Pro Granola cereal by Julian and Catalina Crunch cereal is very acceptable. Keto yogurt, Too Good yogurt, and Yoplait 2-carb yogurts are very excellent and filling. Milk is full of carbs, and I recommend Fairlife milk or 30-calorie almond milk. Avoid rice, corn, grits, and pasta, but you can use spaghetti squash or zucchini pasta. Our goal is to get your blood sugar less than 110 fasting, and less than 110 2 hours after you eat, and less than 110 at bedtime. For insulin-dependent diabetics, I'm happy to, if they get there, blood sugar 140 for those times. Recent experiments have shown that blunting the post-meal blood sugar response, even in non-diabetics, contributes to longevity. It is important to remember that carbs are like cocaine, and the more you get, the more your brain wants. And when you get away from them, the brain forgets about them and does not crave them, and it's easier to stay away from them. Your doctor has many different ways of treating diabetes. He will usually start with metformin. The older diabetic medications like the sulfonylureas, like Amaryl, glipizide, and Diabeta, cause very low blood sugar at times if meals are skipped, and have the possibility of wearing out the few remaining insulin-secreting beta cells of the pancreas, and actually worsening diabetes over the years. But these meds are cheaper and still have value in many patients. Precose, another older medicine, but not a sulfonylurea, is not absorbed in the body and works by inhibiting the absorption of carbohydrates, but can cause gas and diarrhea. Precose was recently shown to increase longevity in non-diabetic animals by blunting the rise in blood sugar after eating. The TZDs, such as Actose, modify diabetes at a cellular level, but can cause salt and fluid retention, so it is used in caution with heart failure patients. The DPP4 inhibitors, the gliptins, such as Januvia, Onglyza, and if kidney insufficiency, Tradjenta, decreases the breakdown of GLP-1 and improves secretion of insulin from beta cells, and decreases the glucagon output of the alpha cells of the pancreas. So there's less output of sugar from the liver's glycogen. The injectable glucagon-like peptide, GLP-1 agonists of the GLP-1 receptor include Victoza, Trulicity, Rybelsus, Soliqua, Bydureon, and Ozempic. They also slow gastric emptying and decrease appetite, which can help patients lose weight. The SGLT2 inhibitors increase the excretion of sugar in the urine to help lower the blood sugar and help patients lose weight. Farxiga, Jardiance, and Incavana are examples of these drugs. Insulin. If you are prescribed insulin, always use the lateral abdomen and do not rotate to the arms or legs, as the insulin absorption is different for these areas. Also, when sticking your fingers to check your blood sugar at home, always use the sides of your fingers, not the tip or the ball. The Freestyle or Dexcom G6 patches for continuous glucose monitoring can be very helpful in monitoring and controlling blood sugars. Long-acting insulin is often prescribed once a day with short-acting insulin before each meal to try to get the 2-hour after-meal blood sugar less than 140. Again, remember, even 6 to 8 pounds of weight loss can help and sometimes even get rid of diabetes. Fasting has become a new effective weight loss method. It can be done safely a few days a week or 16 hours a day by skipping supper. Fasting should not be done if the patient is on insulin or a sulfonylurea. When someone gets the diagnosis of diabetes, it is very frightening and threatening. But it is comforting to know that with tight blood sugar control, a diabetic can live a normal life and avoid many of the debilitating complications of diabetes. Please do not take any of the advice in this talk without talking to your own doctor.